I'd like to thank the doctor for his talk. I have no idea what he said, but I love his passion. So this afternoon I'm going to talk about nutrition in neonates with different types of chronic lung disease. The objectives of this talk are to describe the consequences of poor nutrition in animal models of chronic lung disease and present feeding strategies in the preterm infant who has either respiratory failure or bronchopulmonary dysplasia. I'm going to discuss briefly the potential role of some new, quote, new nutrients in chronic lung disease, and then review some post-discharge nutrition guidelines in infants with chronic lung disease. Nearly 2 decades ago, undernutrition was noted to be a major factor in chronic lung disease. And despite many advances in treatment of preterm lung disease, bronchopulmonary dysplasia, BPD, and its associated significant growth failure remains one of the major clinical problems in neonatology, where people care for very tiny infants. Now, nutritional strategies have the potential to prevent or improve the severity of lung disease and to contribute to post-discharge lung healing. However, at this time, there are no comprehensive evidence-based guidelines for nutritional therapy and evidence in infants with BPD. Keep in mind that we really have 2 eras of bronchopulmonary dysplasia, or BPD. One that appeared in the 80s and 90s when babies got many doses of steroids. There's lots of literature about the nutritional outcomes back then. But now, in the late 90s and early 2000s, we think differently about bronchopulmonary dysplasia, and our treatments are different. Particularly now, we don't use steroids, and that has affected how babies are growing. So what I'm talking about now is really information since the late 1990s and into 2000, not the previous era of management of bronchopulmonary dysplasia. Of interest, a recent systematic review of outcomes, a Cochrane review, that looked at increased energy intake in infants with BPD, found no eligible trials for review. So they did a lit search looking to see if giving more energy would help improve outcomes. And in fact, there have been no studies done on that topic. So these are the type of infant that we're talking about. I have information that I'm presenting to you today, some of which has come from Dr. Van Aerde in Canada. And he has written a lot about nutrition in the respiratory system. When we think about respiratory failure in the infant, it's really a very different disease than that in the adult. Nutrition in respiratory failure is more complicated in neonates than adults. And the reasons for this include, we as clinicians need to provide energy intake to cover energy expenditure, but we also have to avoid nutrition that increases respiratory demands. And we need to meet the added caloric needs for growth in this population. Okay, next slide. So, in view of nutrition and respiratory muscles, it's well known that during starvation, energy utilization and protein synthesis in the visceral organs, such as the liver, spleen, are maintained by skeletal muscle breakdown, leading to atrophy of the respiratory muscles. So these infants during periods of starvation are at risk for having increased muscle breakdown and thus significant difficulty in improving their respiratory status. Unfortunately, there's a minority of preterm diaphragm muscle fibers that appear to be of the fatigue-resistant type, which are seen in adults. In terms of nutrition and ventilatory drive, there's one study that's shown that a decrease in apneas of prematurity occurs in infants who get amino acids and glucose versus those who get glucose alone. So this is one of the first pieces of information that gives us some idea that there are potential nutritional related strategies to improve the outcomes in these infants. Next slide. So this, I think, is probably one of the most important slides of this talk: nutrition, metabolism, and ventilatory drives in infants. Keep in mind, many of the strategies to get babies to grow for a variety of reasons includes giving more carbohydrate or energy as another source. Keep in mind that high carbohydrate intake produces an increase in carbon dioxide production, which in turn then results in an increase in ventilation. Oxygen consumption and carbon dioxide production correlate with energy intake, but not with protein intake. Next slide. This slide shows one of the studies that we did on the relationship between energy intake and energy expenditure in ventilated preterm infants. And this is non-protein energy intake on this axis, a combination of both lipid and carbohydrate, but primarily carbohydrate intake. And this is energy expenditure in kcals per kilo per day. So there's a very strong correlation between the energy expenditure of an infant and the amount of energy intake. Next slide. In terms of determining what should be the caloric needs of the preterm infant, clearly we need to provide enough energy to cover energy expenditure. Ventilated preterm neonates with lung disease can actually decrease their energy expenditure with sedation and with mechanical ventilation. And we've done a number of studies with indirect calorimetry in the 1990s with devices that we built as research tools and studied energy expenditure in a number of different conditions. And when we had babies who were very quiet, sedated, or on significant mechanical ventilation, these infants had basal caloric energy requirements of as low as 40 to 50 kcals per kilo per day. In non-ventilated infants, such as those on CPAP or those in ventilation modes using some patient assistance, energy expenditure requirement is not as predictable and may be quite high. And measuring energy expenditure is very difficult in these patients. We have conducted some studies trying to measure energy expenditure in infants on nasal CPAP. And again, the technique is somewhat difficult, and worldwide there has only probably been one study done on energy expenditure in infants with CPAP. I thought this was an interesting piece of data, and that Mir and colleagues in Europe in 1997 reported that in infants with bronchopulmonary dysplasia, now in the era of new bronchopulmonary dysplasia, energy expenditure increased by almost 1 kcal per kilo per day per breath. So when you're looking at an infant breathing, keep in mind that any stressors that make him breathe more heavily will clearly, very quickly increase the number of calories that they'll need to maintain growth. Okay, next slide. So what should be the maximal caloric intake of the preterm infant? We clearly want to avoid nutrition that increases respiratory demands. So we believe that the maximal glucose intake, and again, lipid does play some role, but most of the energy we give to these infants is in the form of carbohydrate. The goal is to avoid hyperglycemia, which can be associated with an osmotic diuresis. But more importantly, what we think about is trying to not exceed the maximal oxidative glucose capacity. And this term refers to the glucose intake above which glucose is no longer used to supply energy to the infant, and excess glucose is converted to fat. Next slide. Now, we want preterm babies to lay down fat, to grow, to add tissue, but making fat from glucose is a very energy inefficient process. And the adverse effects of glucose conversion to fat include an increase in energy expenditure, increase in oxygen consumption, and increase in carbon dioxide production. In infants receiving IV nutrition with no fat, there's a correlation between glucose intake and CO2 production. So too much carbohydrate, even though in theory a good idea, can be very detrimental to this patient population. So what's the magic number above which we don't want to give more glucose? There have been approximately 4 to 5 studies done over the last 10 years, some by Piero, a surgeon in England, and several done by Bernardi and others in this country, in Canada and the U.S. And on average, those 4 to 5 studies have shown that you probably don't want to give any more than 12 to 13 milligrams per kilogram per minute, which is equivalent to about 18 grams per kilo per day of carbohydrate, again, based on the few available studies. Next slide. This is one of Bernardi's studies, and on this axis it shows non-protein carbon dioxide production, and here is glucose intake. And this is in terms of grams per kilo per day. And in this study, and this is the line we want to follow, this is the study group patients that we want to follow, that carbon dioxide production almost doubled from 4.7 to 7.9 mLs per kilogram per minute when the glucose intake increased from 10 to 24 grams per kilo per day. And the other 4 studies that have really looked at this issue have shown the same thing, that you really need to have close control on your glucose intake. Next slide. Next slide. So this leaves us with the following energy intake dilemmas in ventilated neonates. We need to give the infants enough energy to be able to wean from the ventilator, but if we give too much energy, it may result in an increased PCO2. So in infants with underlying lung disease, this may prevent weaning from the ventilator. So titrating this amount of energy intake in preterm infants is really difficult. And you just have to keep in your mind that you need to watch closely to see if, as your glucose intake goes up, an infant's respiratory condition starts to deteriorate. Next slide. So we've talked mostly about carbohydrate. What about lipid? IV lipid infusions are not well understood. And when you look at